All right, I'm Kieran Anderson, group publisher here at Applied Radiology. We're live at RSNA, and I have the pleasure of having Dr. Manny Kanal in our booth. Dr. Kanal is the Chief of Emergency Radiology and also the Director of Magnetic Resonance Services in the Department of Radiology at UPMC, and it is a pleasure. Dr. Kanal, thank you.
Always a pleasure, Kieran. Always a pleasure to be involved.
We've been doing this for a little while.
I don't want to say how many years or how many decades, but it has been quite a while.
But a lot has changed, and here we are. We're going to talk today about remote MRI scanning. I mean, listen, there was a time when we were just talking about MR safety. Now we're talking about literally doing MR scanning, remotely.
That's exactly right. We're going to be having a patient in one location and the operator in another state.
I'm fascinated. So let's back up. We're going to start from the beginning. I'd love for you to give us a quick update on your role at the University of Pittsburgh, the role you play as the head of the ACR Safety Committee, and even your involvement on the American Board of Magnetic Resonance and Safety.
Sure. In the University of Pittsburgh Medical Center, I am a magnetic resonance safety expert for the site, and I head the safety committee for the University of Pittsburgh Medical Center for the Department of Radiology. I no longer am the head of the safety committee for the American College of Radiology, and we put out several guidance documents for safe MR practices, and the ACR has recently come out with a 2024 version of the ACR manual on MR safety, which was a tremendous, wonderful update that's just, I can't recommend it highly enough. And we've been involved in other safety committees as well, the International Society of Magnetic Resonance in Medicine, American Society of Neuroradiology, and what have you.
Excellent, excellent. As I said from the beginning, we're going to talk about remote scanning today, and I'm guessing you can share some insight on this rather new tool. Tell us a little bit about it. Who's involved? What does it mean today?
Certainly. This sort of grew out of COVID, in my opinion. We have several things that happened with COVID, and one of them was, unfortunately, a tremendous staffing shortage. We found a rather substantial lack of trained, experienced, qualified technologists in magnetic resonance. It's not just in MR. We have a substantial shortage in CT and other areas as well, but we're going to focus now on magnetic resonance. And at the same time, we got used to remote operations. Again, perhaps because of COVID, with a quick kick in the seat of the pants, helping us learn how to do things remotely and have remote meetings with every major company out there with Teams and Zoom and
Right.
Google Meet and what have you. So people got used to remote operations. And in fact, in my own institution, in March of 2020, I have 21 physicians in the Division of Emergency Radiology, and I told them, ladies and gentlemen, we have something unusual going on. There's this COVID disease that seems to be starting to spread. I want you out of the hospital, and I want you reading from home. And at the University of Pittsburgh Medical Center, everyone already had remote workstations in their home, and I told them, go home, start reading all your shifts from home, and I'll call you and let you know when it's time to come back to work in-house.
Right.
And that was in March of 2020, and I've never made that phone call. To this day, everyone is working remotely, and I have several radiologists working in my division that I have never personally met. And they're full-time faculty in our institution. Some of them have never set foot in the state of Pennsylvania.
So speaking from the perspective of, say, like a practicing radiologist in a busy practice, why would this, really be something of interest to them? Why might they consider it? What are the advantages to them, right?
That's a superb question, Kieran. Actually, it really is important for people to understand. Remote MR scanning today, there are just a few ways in which people are using it. Two of them I like to think of as scanning with you.
Mm-hmm.
For example, one way that remote MR scanning is used where, let's say you have somebody who's new, they don't really understand how to do a certain detailed procedure, fetal MR imaging, cardiac MR imaging, something of that nature. So an experienced technologist can log on remotely and can guide you and teach you, this is what I would do, this is how I would do it, and then watch you and vice versa, and you can work together towards learning that skill. So teaching is one application. Another application is where you may have somebody, let's say you have a large institution, and at this institution you have some technologists that can do that cardiac MR exam, but others that cannot. The patient shows up in site A, my MR tech that can do that study and manage to efficiently and safely manage that study is at site B. We can have them log on remotely, scan that patient, and then continue to go back and doing everything else as they normally would. Another example of a scanning with you, where there's a technologist there, but they're actually running it. They're just overseeing some of the safety, and they're learning how, at the same time, how you do it. Both of those I would call scanning with you. But there is a third that I think is the most exciting application of remote MR scanning and the most potentially dangerous.
Okay.
And that's what I would call scanning for you. And that's where Kieran says to me, hey, Dr. Kanal, I've got this company, I've got a whole bunch of top quality MR technologists, you've got a shortage. How about if I scan your patients for you? I'll be location A, you're at University of Pittsburgh Medical Center, you want some technologists, we've got some great technologists. I'll scan your patients on these 4 magnets for you. Scanning for you has the benefits of being able to recruit technologists that may not want to, despite the obvious advantages of living in Pittsburgh and the Pittsburgh Steelers, which of course are the only legitimate football team.
There's that.
There are a couple of drawbacks, and people may, believe it or not want to move to your location. So a technologist that may be exceptionally skilled and capable may have the benefit of living anywhere that he or she wants, and yet still working, perhaps full-time, part-time, in another location, and yet covering patients with their unique knowledge and set of skills without having to move their family, which in a time of difficult staffing shortages, it's a pretty powerful argument for this modality.
There's a big benefit there for sure. So how does one set this up? I mean, it's obviously got to start at an institutional level, I'm guessing, but this could be a busy radiology practice too, I suppose. But how do you really set up a remote scanning environment? Are there specific trainings that are required for both the technologists, maybe even the physicians who ultimately reading? I'm just curious.
Well, I think you kind of hit the nail on the head, Kieran, like you usually do. Today it's the Wild West. Today, essentially anything goes. And there are multiple companies out there providing services of remote scanning. And I'm sure some are superb and some maybe perhaps have room for improvement, but there are no standards today. There is nothing yet in stone. There's no guidance that people can yet follow. And yet people are providing services, I think rather successfully in multiple locations, despite that standardization not quite yet being there. So what we're doing today is trying to ensure that some minimum standards are generated, and in fact the potential for credentialing is created to try to give us some commonality. There's no problem. This is something I think is really important for everyone to understand. We ask so much of our technologists, and they are responsible for everything. It doesn't really make a difference in an MR scanner. In the real world, no matter what it is, it's your job.
Right.
Answering the phone, scanning the patient, making sure that somebody doesn't come in with a wrench and a crowbar, and giving contrast, managing contrast reactions, monitoring patients. Whatever it is, in the real world today, it's essentially, it falls to the responsibility of a technologist. And it's pretty much a thankless job, and it's sometimes too much for just one person to do. So we're looking to create a new situation where remote MR scanning, there's no technical difficulty in having your unique skills applied to that MR scanner, no matter where it's located.
Okay.
The interesting aspect, the part that has to be taken care of, is the safety of doing so. I have no doubts that I can get you to understand what the patient needs and press the appropriate buttons, execute the appropriate sequences. But doing that in a standardized way that safety is not only not ignored, but is the same or better standards than we are working in today.
Right.
That's where the efforts are now being applied in standardization.
That's a really kind of important point, because I was wondering about the safety side of it, right? Because theoretically, the radiologist is responsible in most cases for what
Exactly
goes
right.
on in a level 2, MR suite, while the technologists are in there doing the work. In this case, there wouldn't be potentially a radiologist in the room. Maybe there would be. Technologist might be in another state. We'll get to the software and how that might work later. But from a safety perspective, who's responsible?
Well, that's a fascinating question, and I can't begin to tell you the number of legal cases I've been involved in. It's actually now approaching 500 legal cases in the last 40 years. I can tell you that the Center for Medicare and Medicaid Services clearly has defined magnetic resonance as a medical imaging procedure. And as with any medical imaging procedure, a physician trained in the safe execution of that procedure is going to be expected to be overseeing the safe execution of this magnetic resonance study. So at some point, there has to be a physician involved. At some point, there has to be a technologist involved. And at some point, the site itself has to have adequate site access restriction, and people, if the patient has an adverse reaction to contrast or just has any problem during the study, who's going to run in there? If the technologist, who's one of the most knowledgeable people about MR safety in the entire hospital, if the technologist is in another state, it's almost useless to me how brilliant they are in MR safety if they can't be the one to go in there and manage the emergency.
Correct.
So we're creating a whole new position. And this new position is the MR safety technologist. They're not a technologist in that they cannot scan. They don't know anything from a TR to a TE to a flip angle to a TI. They have no idea about any of those. They don't understand MR imaging physics.
Okay.
But when it comes to the MR safety and overseeing access of the site and controlled access and contrast reactions and things that have to be managed by boots on the ground, it's a whole new position.
Wow.
It's a subset of what we've been asking of our technologists to date. But if you're going to do MR scanning remotely, somebody has to maintain that knowledge on the site. If it's going to be a full MR technologist, then what's the financial model? Why would I pay 2 people to do the job of what before I had 1 person doing?
Right.
So it's a whole new person, a lower pay scale, and in fact, they're going to take their marching orders from this technologist. I want them positioned head first, arm by their sides, center at the canthomeatal line. I want their padding in this location, in that location. This is the screening I want you to do. They're going to take their orders from the knowledgeable MR technologist. But there was an article I wrote in January of this year in Journal of Magnetic Resonance Imaging, and it was entitled Divided Liability Remote MR Scanning. The site will maintain responsibility and liability for things that only boots on the ground, only the site can manage. Mm-hmm. And the technologist will still be responsible for all the MRI related aspects of executing that examination, and the physicians over both of them.
Over both of them. So here's, a question I have from a kind of like what this looks like, right? So you have a technologist who's in another state. Are we talking about cameras and they're able to see the patient and they're at their workstation 500 miles away? How are they, what does this look like?
There's going to have to be live audio visual connections with the patient, with the MR safety tech on site, and the MR safety tech and the MR scanning technologist are going to have to be in contact. Like anything else, there's going to have to be backups that are real time, meaning if the system goes down completely, there has to be a plan. What do you do?
Right.
If you lose all communication in the middle of examination, of course there's a backup plan for that, as well as backup systems for the communication audio visual. All that's part of the standardization that's being created right now.
These are the challenges, these are the pitfalls that do exist or could exist that have to be accounted for.
I think you should learn, I'm a pilot, and I love safety related to aviation, and the FAA, if there's one thing they do understand, it's safety. The FAA has a tremendous lesson for all of us. When you're in aviation, no one tolerates the language. Well, what if you're up there and an emergency happens? It's not tolerated. You can't speak like that in aviation. Literally, formally, you can't say if an emergency occurs. The language in aviation is when the emergency occurs. And it has to be anticipated, And when the emergency occurs, here is the prospectively defined plan to manage it.
Right.
And that's the attack that we're taking here. It's identical. What are the things that will go wrong eventually? Plan for them. Don't be afraid of them. The opposite. Identify them when everything's safe on the ground. Plan for them and define what backup systems you need, what SOPs, standard operating procedures are there when you lose connections, when the patient has this complaint or that complaint, who's managing what, when do you call codes, who calls them, do they quench, do they not quench, what authority do they have, don't they have? All this is taken care of beforehand before you implement a clinical plan for remote MR scanning. Standardize the approach everywhere so that we're all on the same page.
I think that's so important. I mean, you need to have something in place, right? And because this is early days, like you said, it's the Wild West right now. So we're trying to define what this looks like going forward for others. What about like training resources? Are there? You mentioned credentialing. You mentioned, MRST. I think, is that what you said? Magnetic Resonance Safety Technologist.
Exactly.
I know we have safety officers and MRMDs. Tell me about the credentialing.
So the American Board of MR Safety it was formed back in 2015, and it exists to certify. That's what it's for. It certifies the magnetic resonance medical director, magnetic resonance safety officer, and magnetic resonance safety expert. These three were created by a consensus document that was first published in JMRI in November of 2016. We're creating, the ABMRS is now creating a fourth credentialing examination to come out in 2025. And right now we're right on track for that. And this fourth position, MRST or safety technologist, is going to be standardized as well. And the things that they're going to be expected to know will also be published on that site, just like we published for the MRMD, SO, and SE.
Right.
And again, it's an attempt to we can't guarantee anything by simple tests, but at least it's an attempt to identify minimum qualifications. At some point, someone attempted to find, did you have minimum knowledge necessary to be able to be in the position of MRMD or SO? So each one is tested for their specific job definitions and job descriptions. And the MRST didn't exist before. We went out of our way today we're using terms like MR tech aid or a tech assistant or what have you. We went out of our way to ensure that we not adopt that terminology, because the one thing this person is not is just a tech aid. This person is what today's MR technologist is, except that they don't scan. They're overseeing safety. They're not just somebody to go change a bedpan or fetch an IV for me.
Right.
They're there to do the job that the boots on the ground technologist used to do and will continue to do when people are scanning in person. But that can't be done if you're remote. That aspect of their job is now theirs. They're much more than a regular tech aide or a tech assistant, but they're not a full MR tech either. So that's why the title, to distinguish their responsibilities and liabilities of safety technologist.
So where do we go from here? Like, what does the future look like? What would you be telling your colleagues? You're here at RSNA. I've heard other people talking about remote MR scanning. I'm guessing the big scanner companies are involved in this in some capacity.
There are scanning companies, as you know, that are offering remote scanning technology, software and hardware as well. Some of them are offering scanning solutions in the form of technologists. So I would say that today they're part of the Wild West and part of what needs to be standardized.
Okay.
So what I would suggest to people is stay tuned for 2025, because I think you're going to find everything will change once standard definitions come out, standard job descriptions come out, and certification examinations come out. It's all voluntary. Just like today, MRMD, MRSO, MRSE, 100% voluntary. And we have thousands who have already taken and passed the examinations. By the way, I would add that these are amongst the hardest examinations to pass in medicine that people have taken. Passing rates for the SO is about 65, 70%. So I would suggest that once standardization is out there, we'll find that there will be a bar set for people to reach. And I predict that there will be substantial efforts at matching that bar, and people will try to reach the same level of standardization and certification before they open up and offer remote scanning in the future.
Final question, but just dawned on me when I'm starting to think about, the uses for this. Obviously there's workforce situations. We talked about that, why it became necessary under the situations that many institutions found themselves in during the COVID crisis, pandemic. But as we move forward, we're all trying to work smarter, we're trying to work harder, we're trying to bring healthcare to the patient, right? So, particularly in rural areas where there might not be easy access to stuff, could remote scanning, have a role there too?
The word we like to use is that it democratizes the talent. It's no longer that you have to be in an ivory tower to have the best technologists or the best physicians. You can now access anyone with the talent that you need anywhere. It doesn't make a difference whether you're rural or not. If you have remote technology capability, that means it's just a matter of contracting now, finding the people that you think have the talents that you're seeking, and you don't have to even hire them full-time. You can just say, for my fetal imaging, I'd like to recruit you. For my cardiac imaging, I would like assistance with you. Or you can say, take it all over. So this is what I mean by democratizing access to talent. The academic sites had tremendous draw in the past. I think they still will. But they're going to be given a run for their money because the technologists are worth their weight in gold. They are the scarce resource now, and they will call where they wish to work and the conditions under which they want to work, just like when remote ability to read and interpret studies remotely came out. There's job, I'll finish with this. I got a job notice in my email this morning. There's a job available in, I'll just say, the East Coast for neuroradiologists that are interested, and these are the hours, this is the salary, and these are the benefits. If you only will read remotely, quote us the dollar value per RVU that you require. So it's turned the entire industry around. When the remote talent controls, they'll tell you under what conditions they'll be willing to work and not work. I also think that this might perhaps provide new value to the position of MR technologists in the first place. People would now recognize more what a scarce talent it actually is, and perhaps they'll start to get, the full technologists will start to get remunerated perhaps a little bit more appropriately for all the things we've always asked them to do.
Very interesting. Well, Dr. Kanal, we covered a lot here. I want to thank you for taking the time to come sit down with us here at Applied Radiology, here at RSNA. It's always a pleasure.
It's an honor and it's a pleasure to continue this relationship. I'm glad that you had the interest in talking about this, and I think you'll find that there'll be a lot more interest in the future.
Thank you again, Dr. Kanal.
Truly a pleasure.
All right.
Thank you.